Imagine a scene like this. A woman, 34 years old, is leaving for work. She's in a rush for her train. She stands in front of her front door, checking to see if it's locked. Once, twice, 3 times. She walks away a bit, but comes back to tug the handle one more time. And she walks away again. And she comes back again. She repeats this many times. She arrives at the station late. Along with the train, her important tasks for the day slip away. She knew perfectly well that the door was locked, but what she knows doesn't match what she feels at all. How many times have you heard someone casually say, "I really hate a mess. It's just my little bit of OCD." Or, "Isn't OCD that thing where everything has to be perfectly lined up, right?" No, that's not true. It doesn't always have to be lined up, and it doesn't have to be sterile for us to call it OCD. Because we need to be very clear about this. OCD is not a personality trait. It's not excessive perfectionism or being a neat freak. It's a disorder that the WHO has placed on the list of the 10 most disabling diseases in the world in terms of how much it destroys quality of life and the ability to function healthily every day. Stay with me until the end. I'll show you what OCD really is, what it definitely isn't, and why that difference matters so much to anyone who's ever thought, "There's just something wrong with me." Let's start with the specifics, from the foundation. According to the DSM-5, the most important diagnostic manual used in psychiatry and psychotherapy, we diagnose OCD when obsessions, compulsions, or both appear. What are obsessions? They're those intrusive, totally unwanted thoughts, images, or impulses that pop into your head uninvited and cause paralyzing anxiety. The key word, unwanted. You don't want them, yet they attack you. And compulsions are all those rituals you perform to somehow lower that anxiety. It could be checking, counting, hand washing, arranging things, or constantly asking others for reassurance that everything is okay. And here's the trap. A compulsion provides relief, but only for a moment. And paradoxically, it's that temporary relief that makes the obsession come back even stronger. To make a diagnosis of OCD, there is one more absolutely crucial condition that must be met. These symptoms must take up more than an hour of your day and significantly interfere with your daily functioning. This isn't just a moment of irritation. It's an hour, 2, sometimes 8. It can result in hands bleeding from washing. It can be physical exhaustion after repeated rituals. And one more important thing. The DSM-5 notes that a person with OCD is usually aware that their anxiety is irrational. How many people are actually struggling with this? A study published in 2025 in the journal BMC Medicine, which was conducted across 10 countries, showed a lifetime prevalence rate of 4.1% for OCD. 4.1%. Meanwhile, the 12-month prevalence rate for this disorder was estimated at 3%. Other, slightly more conservative estimates, cited by StatPearls and in clinical studies, suggest 1 to 3% of the global population over a lifetime. Translated to Poland, this means from 380,000 to over 1 million people. Stop and think about that number. This isn't some rare exotic condition. You can actually meet people with OCD anywhere, in your family, at the office, or at your children's school. But another fact strikes me even more. Research shows that from the first symptoms to a proper diagnosis, an average of 11 to 17 years pass, even 17 years. That's almost an entire youth spent in shame, isolation, and the fear that you're going crazy. Why does it take so long? Because as a society, we have a completely false image of this illness in our minds. And that's exactly why I'm making this video, to change that.
For over a decade, I believed I was a bad person who had to hide my darkest secrets from the world. I didn't know that these terrifying images and compulsions were an illness, not my identity. So, instead of seeking help, I fought for survival every day in total isolation. Today I feel relief that it has a name, but it hurts to think of that girl who lost her entire youth because she was ashamed of herself for even feeling and thinking.
Let's go back for a moment to the year 1978. Rahman and Da Silva did something groundbreaking back then. They asked ordinary people, those without any diagnosis, if they ever have terrible intrusive thoughts in their heads. Thoughts of hurting someone, blasphemous images, sexual ones, or something they're deathly ashamed of. The result? Over 80% of those people admitted, yes, I have such thoughts. This study changed absolutely everything. It showed that the strange thought itself that pops into your head isn't a symptom of illness. Almost every one of us has them. The difference is in what you do with that thought. Someone without OCD will think, oh, what a weird thought, where'd that come from? And goes on to, for example, drink coffee. A person with OCD thinks, I had such a thought, so I'm a monster. I have to make sure I didn't do anything to anyone. I have to check it. See the difference? It's not the thought itself that's the problem. The problem is your reaction to that thought. Now it's time for a quick series. We'll debunk the 5 most common myths about OCD. Myth 1. OCD is just a love for cleanliness. Nonsense. Yes, there's a subtype regarding cleanliness, but OCD is also obsessions about religion, sex, aggression, or relationships. You can have harm OCD, which is the fear of hurting someone. Such a person is afraid of kitchen knives not because they want to use them, but because they're afraid they'll lose control. And that has nothing to do with organizing socks in a drawer. Myth 2, just stop thinking about it and you'll get better. Have you heard of the white bear paradox? No? Okay, so let's try a little experiment now. Close your eyes. Ready? For a few seconds, try not to think about a white bear. Don't think about a white bear. Don't think about a white bear. And? Do you see it before your eyes? Suppressing thoughts works like adding fuel to the fire. In psychology, we call this the rebound effect. Myth 3. OCD is a lack of discipline. Get a grip. Yes. Except it's not a matter of weak will, but neurobiology. Studies by Brock and Hanna from 2024 clearly show changes in brain activity, mainly in the frontal lobe. The heritability of OCD is estimated at 40 to 65%. Telling someone with OCD to get a grip is just as effective as treating diabetes with willpower alone instead of insulin. Myth 4. OCD is visible to the naked eye. Well, no, not always. There is a subtype called pure O. Here, all the rituals take place in the head. Someone might look like an oasis of calm, while inside they're going through a hell of analyzing, counting, or praying over and over to prevent a catastrophe. Myth 5, you just have to live with it. It's incurable. This is the myth that probably hurts the most. There is ERP therapy, which is exposure and response prevention. Studies published in PLOS ONE confirm, in 60 to 80% of patients, this method brings huge relief. OCD is not a life sentence. Now imagine a loop that spins endlessly. It starts with an obsession, an intrusive thought. Then anxiety appears. You feel tension, a racing heart, you break out in a sweat. To quiet it down, you perform a compulsion. For example, you check the door or count in your head. And then comes temporary relief. And this is the moment when your brain gets caught in a trap. This relief teaches your brain that the ritual works, that it's the only way to save yourself. So next time the thought appears, the anxiety will be even stronger. It's classic conditioning. That's why in treatment we don't fight the thoughts. We fight to survive the reaction to that thought. If you've made it to this point and feel like I'm talking about you or someone close to you, it's good that you're here. OCD feeds on silence, shame, and isolation. It wants you to believe that you're the only person in the world with such strange thoughts. But that's a lie. You have the right to a diagnosis. You have the right to effective treatment. You have the right to get your life back. In this series, we'll deal with each subtype one by one, from relationship obsessions through fear of aggression to religious compulsions. I'll show you strategies that really work. Subscribe to the channel so you don't miss the next part. See you every Thursday at 7 p.m. And remember, treat yourself with the same kindness that you show to others. I'll see you again next Thursday. Bye.